Hey everybody, it's Kevin and it's Donna, and we're really excited to be here with you on this episode of the Med List. Donna, the piece we're talking about today, it's kind of a tough one. In fact, when you presented it to me on, who our speaker was going to be and the expertise level, it almost gets a little bit emotional, like talking about some of the subjects because, we care so much about our families. We want to make sure we're making the right decisions for them. And I'm really looking forward to Veronica kind of leading us along the way with that.
Yeah, for sure. Yeah, and I think having that that expertise of functional medicine and her background of farm to table and all of this that we can also learn about. I'm excited.
Absolutely. Okay, let's get rocking. I think that's a perfect kind of intro because reading through Veronica's background is very impressive. Like just seeing an individual that has been in clinical practice, that has the geriatric background, that has the functional medicine expertise, that also can talk about really difficult subjects like the one that we're going to kind of work around here with end of life medication decisions and decisions that you can make, as Veronica was describing off screen, even before the end of life that can ease some of the burden that you're taking on for your family, yourself, et cetera, at those end stages. So, without further ado, I think, Donna, let's talk a little bit about what's going on in the life of Donna.
Oh, well, life is busy. I decorated this weekend for the holidays, so Christmas is up in my house, which is lovely. And yeah, so just trying to. I feel like I'm ahead of the game, which I shouldn't say that. So that doesn't really happen very often.
That's
so
perfect.
so I'm doing well.
Is the
I'm
season to
trying
be proud
to
of being ahead.
de-stress. I'm trying to give myself less stress this
Good.
holiday season. So
That is an
important.
important place to be
Yes,
with
it
less
is.
stress. Yeah, the Walker household, we do have the Christmas lights are up. Savannah let me do
Mm,
I shouldn't say this, but I'm gonna say it anyway. Savannah let me put lights up that we can change the colors on the lights
mm.
so that we can leave them up for different seasons, like of the year. And I am super
Oh.
excited about putting them up once and getting to enjoy them throughout the holidays. Some people would call it redneck. I call it high levels of efficiency.
Absolutely, absolutely. Well, there are some trees that we actually do keep some lights on because if they're white lights, you can use them all year long. So
I
we
can't.
do
That's
have we do
classy.
have a couple of those.
Well, perfect. Well, I want to bring is all the fun Veronica with us here right now. And if you would do the honors, Donna, of introducing her on the screen.
Yeah, of course. So, hi, Veronica. Thank you so much for being with us today. So, we have Veronica Riera-Gilley with us, and she is specialized in so many areas, but a doctor of pharmacy and board certified geriatric pharmacist. And that's where our roads have crossed, which has been just amazing that um, we're able to. Share our information and really learn from each other. We say that all the time. We learn so much from each other. But what is very unique for me about Veronica is the whole idea of the functional medicine. I still don't feel that I'm really up to speed 100% on that. And also the whole farm to table. I believe you're a member of the board to farm to table, if I have that right. I was trying to get my notes up. They were up and then they disappeared. So, but anyways, and I find that fascinating too because I think it's so important. We think about farm to table, but what about pharmacy at your table with the foods that we eat and the nutrients that we take in? So I love that idea, and I think it's just so important. So welcome, Veronica, and please fill in all the gaps that I have completely left out that you do so much.
That was a great introduction. Thank you. I don't think Farm to Table has an official board yet. I'm one of the members of the leadership team, and
Mm-hmm.
I help support the other members and with mentorship, and I connect people and I
Awesome.
talk to everyone. That's what I do is I talk to everyone and I say, what do you need? And I try to connect them within the group of Farm to Table and figure out
Yes.
which pharmacists have which specialties and who's needing their expertise and trying to connect them within the group because we're growing so much.
Right.
It used to be a small group of practitioners and now we cover
Mhm.
over 40 states.
Wow.
Awesome. And you are a great connector. I just responded to one today. Need to connect you too. So thank you for that. You are a great connector. And I think that you also connect so well with your clients that you have and thinking about their needs and really getting to the root cause of problems that people may have. So do you mind just sharing with us a little bit about your background in that regard of how you really dig in to really getting down to the root cause and what that means for how patients are treated that you are aiding with?
Sure. Well, I was exposed to functional medicine through my yoga practice. I heard Dr. James Gordon, he's the founder of the Center for Mind Body Medicine. He was speaking at a yoga conference that I was attending, and he invited people to his food as medicine professional nutrition training. And it was there that I was to this concept of functional medicine, where you're asking the question, why? Why is your body having this symptom? Why is it no longer able to keep pace? And why are you developing this symptom? So I thought this was great. And I knew this was the answer to polypharmacy. If we start asking, well, why can you no longer maintain your blood sugar homeostasis or your blood pressure in good ranges? So what's going on? What is your body missing that it's no longer able to do this for itself? Because it's happening earlier and sooner. And I also learned, this was my first exposure to epigenetics, where we are not destined by our genes, but that our environmental inputs can drive the expression of our genes. And so we can have a beneficial expression of our genes or a negative expression of our genes. And thinking about our environmental inputs, so thinking about our stress or different pollutants in our home or the body care products that we use, thinking about every layer of our health is what I learned at Food as Medicine nutrition training.
I love that. So with that mind over body kind of mentality that you're talking about, Veronica, and saying that it's much deeper than the placebo effect, right? I mean, the placebo effect of saying that we're thinking about a positive kind of outcome overall with overall healthcare and thinking of it as being just a good mindset really takes away from some of the scientific inputs. Can you help break that down, Veronica, a little bit for our patients that are listening, that they can kind of understand what does it mean when you're saying like reducing my stress and how that can actually be good for me with the way that I'm thinking or the way that I'm living my life?
Yeah, I'd be happy to do that. One of the ways that I start off all of my medication reviews with patients is we sit down together and we take 3 deep breaths. And then I ask them, how do you feel after this? And we pause both before and after the 3 breaths to notice what's happening in our body and have a benchmark for how we feel before and after this practice. And I let them know that their breath is the on switch to the relaxation responses in their body. And our bodies have to be in this relaxation state. When we're learning about it in pharmacy school, we learn about the 2 halves of our central nervous system. We've got fight or flight and rest and digest. So using our breath helps to put us in this rest and digest mode so that we can receive all of the different healing choices that we're making, whether we're receiving medication or we're changing the foods that we eat or we're moving our bodies differently. We still have to put ourselves in that relaxation state or rest and digest state in order to receive all of these benefits that we're doing. Because if we're in that fight or flight state, our body is going to prioritize its resources differently, and it's not going to rebuild and repair our bodies so that we get better from whatever disease challenges that we're having. So that's where I start in talking to my patients, is that it starts with their breath, and they have this simple and free tool to use at any time. And then we're going to continue our conversation in that medication review. We're going to talk about what's working, what's helping, what's hurting, and what are the things that they can do outside of the pill box to start helping their situation. And I like to ask patients a 4th question. Did you guys learn the 3 prime questions in pharmacy school?
Which 3?
Certain, I know.
What did the doctor tell you this was for? How did he tell you to take it? And what did he tell you to expect? And I ask a 4th one. What else are you doing to support whatever health condition that this is treating? So if it's a blood pressure medication, that 4th question I ask my patients is, and what else are you doing to support healthy blood pressure? And that leaves the conversation open for us to talk about different food choices, and movement choices, because, and this is also my way to let them know that this is not a life sentence. Your prescription, we don't want you to take this forever. Let's have a deprescribing conversation up front and talk about what can you do to reduce your need for this medication lifelong.
That's beautifully said. I think that those conversations have come up for me recently, Donna, especially around statin therapy. When we see more and more individuals being prescribed statins,
Yeah.
oftentimes these individuals that are primary prevention, meaning that they haven't had a diagnosis of a previous disease state or haven't had a cardiac event or stroke, et cetera, are on these medications. And that can be a real feeling there, Veronica, of being helpless. Same thing with migraine prophylaxis. Just had a question about that today of, I was put on this new drug or this new drip, whatever the case may be, and now I'm going to be stuck on it forever, and I'll never be able to get off of this, because the mindset early on is this drug is the cure. I can't find another way to be able to treat this or another modality to go about it. So when we think that way, I guess, Veronica, how do we help both our patients and our clinicians to be able to think about things outside of what they're going to experience during that 7-minute visit with their provider?
Say that question for me one more time, please.
If we want our patients and our clinicians to get out of that 7-minute box. So in other words, you're there for a very short period of time. You're treating something from an acuity perspective. So in other words, you come in with an issue. The clinician is thinking, how do I address this issue, this particular issue? How do we allow for both our patients and our care providers to start thinking about it in a more holistic way?
I do my part in asking that fourth question. What are you doing outside of this? And introducing that idea that there is something besides the pill. And I feel like I'm often the first person who's telling them this isn't a life sentence, that there are other things you can do to help manage your blood pressure besides this pill.
So that is something that you'd say to bring into that conversation when you're talking with your clinician, you're going to your primary care provider, having that question ready and prepared of what else can I do? Like what other things can be done besides this medication, and fill me in on dietary, lifestyle, et cetera, things that you know of, or refer me over to an expert like Veronica that can help me kind of walk through those next steps. Okay. That's super helpful.
I also encourage them to ask for PT visits or ask for other referrals, whatever it is I identify in talking to them that, they could benefit from the help of someone else's expertise. I ask that they go back to their doctor and say, hey, get this PT referral, especially for patients that are dealing with chronic pain. We're lucky enough in my community, we have some physical therapists who are trained in pain neuroscience education. So really helping patients understand how pain works and how they can have different skills to learn how to overcome their chronic pain without more medication. And it's a wonderful thing that we have these providers with this extra layer of knowledge. So I make a lot of referrals for my patients who take pain medications to the PTs in our area that have that specialty, because it's a whole different type of care when you have someone who really understands what's going on with your nervous system. And when it's turned up, the volume gets turned up really loud in your nervous system when you have chronic pain, and they help you learn to turn the volume down.
Yeah. I think it's really important that we take away, you're going to be on this for the rest of your life conversations in general, because we don't know necessarily how long someone's going to be living. And if we can get things under control and they're having, healthier outcomes and being able to make some of those lifestyle changes and maybe changing, their diet more appropriately for the nutrients that are necessary. But I think our older adults right now are still in that mindset because they heard it for so long. So many years ago, they're on meds for like 30 years. 30 years ago, that was the conversation. You're going to be on this for the rest of your life. So we're still having to deal with that. I think younger patients might not be hearing that, but we really have to change that mindset of older adults saying, we're not giving up on you. This is important because you are now this age and, you've done well so far. You just don't need this any longer. We need to switch this for you.
Yeah, I think that leads in so well, Donna, to what Veronica was talking off screen about, is just by making some of those decisions early on, by making some of those health related decisions, not medicine related decisions, but health related decisions, we allow for the end of life to sometimes be a little more graceful overall and to give us more options. When it comes to those additional options you may have, Veronica, and kind of expanding the way that you can live the end of your life with these changes that you talk about earlier on, can you describe a few of those situations and circumstances you've encountered with patients or family members?
Yes. Thank you for asking. I really love sharing the story of my grandmother. My grandmother took really good care of herself throughout her life. She lived to be 91 years old, and she only took one medication, and it was thyroid medication. She did everything in moderation, and she was very clear with what she wanted with the end of her life. And when she was experiencing chest pain, went to the emergency room, we found out she was having a heart attack. They wanted to take her to the cath lab. And she said, nope, call hospice and send me home. My family called me back and they said, do you think this is a good idea? And I said, I think she's making a really sound decision. We are not guaranteed the outcome on the other side of that essentially surgical procedure.
Yeah.
And we don't know what kind of quality of life that she's going to have. And she told us very clearly she wanted to die at home. And if she accepts more medical care, we're not guaranteed what the end of life looks like. So she gave us a gift in us not having to guess about our decisions moving forward and to call hospice and to help make this happen.
Wow.
And it gave us a wonderful end. We all got to say goodbye. Everyone had time to travel up and see her and say goodbye. My children got to say goodbye. Had she been in the ICU, many ICUs have policies. They don't let children in. So I don't know that they would have got to say goodbye if she had made other choices. And we could feel good about, I think in some ways families can think it's withholding care, but she made that choice. So we didn't have to feel any tension about, was it the right choice? Was it not the right choice? It was her choice. So it was the right choice.
That's beautiful. Man, thank you so much for sharing that, Veronica. I think there's real difficulties toward the end of life of being able to respect individuals' cultures and family members' wishes to say goodbye and say goodbye in the way that they want to. And doing that in an institutionalized or facility setting is just more difficult, overall. And, not entirely to the detriment of those facilities. They're trying to do their best. Many of them are, and trying to change policies and procedures to allow families to do the things they need to do, but it's not perfect. And allowing someone to be able to be home and that individual making choices early in life so that they are at home, and knowing exactly what they want their family to be able to celebrate them or connect with them in the way that is necessary is really a beautiful gift. When it comes to the decisions your grandma made, tell me this. She was only on a thyroid medication. Most individuals that live to the age of 91, that we think of their medication profile, all three of us have geriatric backgrounds in one way, shape, or form. We do not think of a medication list of one.
Right.
I don't even think of medication lists under 7. So seeing an individual with a medication of 1, what were some of the things that she did, and I'm sure inspired you in lots of ways, to do with her life that you thought, wow, I'd love for more people to take a page from Grandma's book here?
She did everything in moderation. She loved to drink coffee. She loved her chocolate, but if she had a chocolate bar, she would cut it in thirds and she would share it with someone, or she would save it and eat it throughout the week. I saw her do everything in moderation, and she was always very active. She loved to go out, be in the garden.
Social lifestyle. I mean, how did Grandma have lots of friends and visit with folks, or folks come over to her place? I'd love to hear more about her.
Yes, she was very active in her community. And once she was staying with my uncle, and my uncle passed away before she did. And so she moved in with her other son, so my other uncle, and he took care of her, and he took her to church and took her to do all the things. And yes. So the social activity, you're absolutely right. If we are not connected socially, that is a huge detriment to our health. And she also had a big spiritual practice. She loved to play the piano and sing hymns. And something that was really great about her end of life experience is that because it was not medicalized, or I feel like this is because it was not medicalized,
Yeah.
that we got to really tune into some of those spiritual pieces of her passing, things that we only hear about. We,
Yeah.
as a Christian, we're taught, angels greet you and come help you cross to the other side. And she was starting to see those things. And she told us that she heard a man call from the mountains, come home.
Wow. Wow.
So she could tell us those things. And I wonder, would we not have been able to share in those experiences? One of my sons could sense the angels that were waiting for her. He said, Mom, we're being watched. I said, what are you talking about? And I realized like the angels were waiting to help her cross. And my, children are much more connected spiritually, I think, than adults. And he could sense that.
That's beautiful to be able to have that kind of spiritual connection with that end of life. And I think that Donna and I have talked many times before, about our family members that are either nearing the end of life or that have passed previously. And just some of the beautiful things about them wanting that level of connection, with individuals. And I love that you address that kind of throughout your talk about what your grandma did beforehand, because being connected and not institutionalized in an assisted living facility, long-term care, whatever the case may be, like it feels like societally we're trying to find more and more ways for individuals to age gracefully from home, right? I mean, that's a big push because of, fortunately or unfortunately, cost elements, right? When it comes to providing care, some of these settings are very expensive. Interestingly, I think that it aligns very well with what the most successful way is for someone to live and age gracefully, is for them to do it in their own home with individuals around them that love them and care for them. Tell me this, Veronica, when it comes to when we're talking societally and from a community perspective, not just about our, our loved ones, how do you think those elements of care, we can re-input them? I know that folks listening right now, you're probably thinking, I thought the show is called the Med List, and you guys are talking nothing about a med list. And that's the beauty of it, is that here, like, we're able to avoid these medications by inserting life more often, like real connection with human beings. How do you think we can do that better, Veronica? Because that really, you read anybody that looks out there and sees like some of the leading causes of death or morbidity or mortality. If you go out there and search loneliness right now is one of the biggest buzzwords in all of medicine that people are the most worried about, that's going to cause more issues in our elderly populations. If you could humor me for just a few minutes, Veronica, on some of your thoughts on trying to address that, I'd love to hear them.
Well, we look at other cultures and those that take care of their elderly and don't put them in institutionalized settings have multi-generational homes. And that's how my grandmother was able to live so independently, was essentially a multi-generational home. She moved back in with her son and she was very independent. I don't know that he needed her. It was more the community and the connection that she had in those later years that really sustained her. But thinking of different ways to create community, and you're absolutely right. Loneliness. Have you read The Community Cure by James Maskell?
I haven't yet.
It's a wonderful book about group healthcare and how we can really make a huge impact, and that the things that patients are learning in those group settings, they're really filling each other's cups, and that's where a lot of the work is getting done.
Wow. No, I think
It's a great book.
Beautiful. I definitely will put that on the reading list. Everybody that's listening, write that one down. And so when it comes to some of the perspectives I've seen, Donna, of late, like I'm seeing more and more things, and Donna's probably like, Kevin talks about this all the time, but I'm seeing more things about using community health workers. And once again, that's pulling from other cultures that have used members of the community that are highly integrated, know families really well, and start leveraging them to connect them with care, with socialization, with all these other kind of aspects. Donna, other things that you've seen when it comes to addressing loneliness and end of life elements that may be related to just getting people to be with the ones that they love or finding people to love them?
Yeah, so I just want to back up just a little bit too, if you don't mind, while we get to my thoughts and all of this wonderful conversation is thank you for sharing that great Christmas message, for one thing, Veronica, because I know not everyone listening is necessarily celebrating Christmas, but pretty neat to share that and to share that spirituality. So thank you for that. I think what we hear a lot, if people who take more than one med, and when they are facing end of life, and values, and trying to understand, the difference between palliative care and end of life. And we will have some speakers on next year in regards to a physician that actually specializes in that. But we often will hear people say, "Oh, yeah, they took all the meds off of my mom or grandmother, and gosh, it's like we had her back." I just had that conversation today with somebody who was learning about what I did, and they're like, "Gosh, I wish I knew you 10 years ago, because when I lost my mom, is she was so over medicated." And one doctor finally said to me, "Do you see this list? Like, she's been so over medicated." And they took off many of the meds, and he said, "We had our mom back for the last few months." So we can do that earlier on too with what we're doing, and hope for better options. Talking about socialization, Kevin, and how we engage with people, we got to look at their med list too. We can't just say, "Oh, go and be a part of this," or, "Oh, I think you should do that." If someone's dizzy, lightheaded, unsure of themselves, cognitively aware that they're not so cognitively aware, because that happens when people start, not being able to, remember everything, or they feel embarrassed or whatever it might be, they're not going to go out as much. So people isolate themselves, and sometimes it's because of the meds that they're taking. So because of that, we really got to be proactive, even well before end of life. And that's why I think, Veronica, your whole piece of, functional medicine, and the farm to table, and thinking about all of this so that people have a healthy life, so they are on only one medication maybe, and can, not say, I've had a good life, I don't want to have all of these heroic efforts being made. So I think that that's really important, that we look at that. So Kevin, to answer your question, and I you're probably a little bit surprised that I came back around to this. I guess I always come back around to this, is that we got to be looking at meds and seeing what effect it has on people. Is it causing them loneliness? That is a real thing. So we want to be careful about that. Also, talking about like that multi-generational living space. I grew up in Worcester, Massachusetts. We are the capital of three deckers. And that is what they were really used for growing up. And, we had multi-generational families, and my dad's multi-generational families. There was aunts and uncles and grandparents, and on every single floor of the three deckers in Worcester. So if you look up Worcester, Mass, three deckers are huge. It's like one after the other. And that was part of it. It was families coming over, building three deckers so they could continue to live together independently, but together. They're always there for each other.
Oh, that's beautifully said. And thank you, I think, for giving us that chicken and egg element there, Donna. Like, sometimes maybe the loneliness is caused by those medications. And Veronica, I guess from your perspectives, then, if let's say that that's the case, an individual, and we see it so often that this individual doesn't want to stay out past this time, or they can only be gone for this long. They don't want to go to the restaurant any longer. And in our minds, we're just thinking, well, they're just getting older. And sometimes that is not the case at all. Sometimes it's a disease state manifesting itself in a way that we're seeing some symptom elements that they can't control. They may feel embarrassed by, whatever the case is. So from a functional medicine perspective, and when we're starting to look at that chicken or egg with isolation, loneliness, depression, medications that have been thrown on board, what are some of the things that you've seen on some of the patients' profiles you reviewed that you went, this is causing some issues related to what Donna was talking about, with some of that loneliness and isolation that can impact them and kind of detour the end of their lives?
Anticholinergic burden, I think, is the biggest one causing cognitive deficit or challenges to their memory. And I just talked about this at the Alzheimer's Association this weekend, talked about the importance of medication review to hopefully prevent cognitive decline, that some of this cognitive decline could be reversible because it's medication induced. Mm-hmm. So we talked about that importance. And I feel like anticholinergics is probably the biggest one. What would you say, Donna?
Well, it's funny because I said, thank goodness I'm not the only one saying it, because I think I bring up anticholinergic burden, I think pretty much every week because it is so important. I just gave a talk this morning to a bunch of pharmacy clinicians, and that's what we were talking about. But was part of it is the frailty, the anticholinergic burden, and trying to reduce that. The big issue, though, that was brought up, and it's been brought up in many of the conversations I've had with those that are, working with electronic records. Why is that number available? Can we have that available in our electronic records? What is the AC burden? Can that number appear? I know that some have, readmits, or they might have lay scores or things such as that. Why can't we have an anticholinergic burden score in the electronic records so that people don't necessarily have to take the time to calculate? It's right there in their face. This person is over 3 of an anticholinergic burden. We've got to take care of this. So I think that that's super important.
I had a 40-year-old patient who had an anticholinergic burden score of 21, and she was on all kinds of constipation and other medications. And I said, we can make a big impact on this constipation if we address this anticholinergic burden.
Yes, absolutely. Absolutely.
And we did. We got some movement. No pun intended.
Movement from prescribers and from the patient.
Yeah, I think the only one that I would add to your guys' anticholinergic burden list is pain treatment. So more and more often, we think of pain treatment as being something that could be over the counter. We see more and more acetaminophen and ibuprofen, et cetera, being used. So common things we're reaching for. There's more and more studies and cases out there that have headache related to chronic medication utilization, that the drugs themselves are causing more headache, and that's usually related to pain. But one thing that we don't think about with pain, the opioids are very obvious and can cause problems. And once again, the movement issue is related to it, but it's alcohol consumption. And so being able to look at your patients and have a conversation beyond the pills in front of them, to be able to know that alcohol is a drug and is used oftentimes by individuals dealing with different sorts of pain, can be very problematic in our older populations, dealing with diabetes, dealing with fall issues, dealing with social isolation. All of those pieces, I think, can play a major role. And if I had another one to add on top of anticholinergic burden that we oftentimes see, and it's so funny because I was just been looking at patient profiles that I feel like hydroxyzine is a new favorite in the 70-plus-year-old patients. Like it's re-emerging again. So all those individuals that are patients out there that are listening that aren't clinicians, can you go over real quickly, Veronica, how you describe anticholinergics? Like I know it sounds like a big, scary word, but for individuals that aren't in the clinical world so that they have a better understanding of what we're talking about there.
Yeah. Every medication that causes anticholinergic side effects has this list of side effects. And we have a mnemonic: hot as a hair, red as a beet, help me full as a flask. I'm going to get them all wrong without my slide. But dry. So you've got dry eyes, dry mouth, heat intolerance. So you're not sweating as much. You're not able to regulate your temperature as well. You can have urinary retention, so not being able to completely empty your bladder, and rapid heartbeats. And I'm sorry, I completely goofed up the mnemonic on that. Do you know what it is, Donna? Do you know what I'm talking about?
I should. They still teach it. I'm not the one who teaches it.
So when I'm teaching other clinicians, like physical therapists, I will use that slide and I will show them, like, look at how far reaching these side effects are, and how often are we taking something else to treat these anticholinergic side effects, like dry eye and dry mouth. We are adding saliva substitutes, or we're adding eye drops, or we're getting more invasive dry eye treatments like IPL, so the laser treatments, or we're using immunosuppressant eye drops like cyclosporin eye drops to help with the dry eye. And a lot of it could be medication related, or we could reduce it enough to where it's not so problematic if we were looking at medication cause.
Here it is for all listeners out there. Red as a beet, dry as a bone, blind as a bat, mad as a hatter, hot as a hare, and full as a flask. So
thank you.
And I am literally looking at on the other screen. So please don't blame Veronica at all for that one. We've all used it. I'm teaching
Well,
students
yeah,
about
it's
it.
just,
But it's a long kind of breakdown, but it really does help the audience to go, these drugs do a lot of things. And
Mhm.
that can be a problem and can be a benefit. I had a mentor that once said, if a drug does not have side effects, it's not effective. So they have to do something. But when it comes to the extent of side effects and be able to manage those, that's the difference with anticholinergic in particular. They have a widespread, almost shotgun kind of feel when it comes to what ends up happening with them. What are
Mhm.
some common anticholinergics that our patients could encounter that they might not even realize, Veronica?
Tylenol PM, Advil PM, anything with PM in it. I have so many people, like, we uncover that in the medication review, and they're taking something for sleep. And so over the counter sleep aids or any of the pain aids that have PM in the name will have an anticholinergic in it. A lot of allergy medications, Benadryl in particular is the big one because it crosses into your brain, causing more memory impairment and sedation or sleepiness, feeling groggy, hung over the next day.
Yep. And for all of
Those are
you
the
that
big
are
ones.
listening and flipping your bottle over to look at it, you'll see
Mhm.
Benadryl, PM, and diphenhydramine are all the things that are synonymous with what Veronica kind of laid out there for you if you're looking at your OTC bottles, either with your mom and dad or yourself.
Yeah, absolutely. And anything that, we see a lot of patients on medicines for urinary incontinence, and many of the older um, medicines do have that as well. So oxybutynin is a very common one that we see.
Oh, that's super helpful. So
And of course, your hydroxyzine that you brought up.
We see that a lot for anxiety in older adults. I guess they're trying to avoid
Yeah,
things like lorazepam or the benzodiazepines, and they're using something anticholinergic. And
right.
I don't
uh,
know that that's a
Yeah.
great switch.
And I think you bring up such a great thought there in regards to, and I bring this up too in MedStrong, that just because there's a change in a med doesn't mean it's the right change. And even if you're thinking about like pain relief, is somebody going from an opioid to tramadol, which they think is a safer alternative, and it's not helping older adults. It can be worsening and can cause falls and cognition issues too. So it's not necessarily any better. Or sometimes they're avoiding opioids and starting with tramadol, which is not necessarily a great drug anyway. Thinking about gabapentin too. What are we using it for? Trazodone for sleep. People, prescribers think that it's a safer product for sleep. It really isn't. So we got to be thinking about maybe these off-label and other ideas that people are using meds for, and it just isn't appropriate. So sometimes the switch still needs to be thought about. And just because a med is switched doesn't mean that it is the best alternative or that's something that you should remain on. I should remain on because it still might only be necessary for a short period of time.
well, and especially with Veronica's background, I'm curious on this perspective. So I talked about that mentor saying if it doesn't have a side effect, then it's not effective as a drug. But that doesn't mean we need to use drugs all the time, right? And so I think that is the other alternative, that we don't have to have something that has a very pronounced side effect and problem if we look to non-drug alternatives, Veronica. And if you can, walk us through a couple things from a functional medicine perspective. You've got a number of end of life issues that end up happening with a number of folks. So, decreased sleep or difficulty sleeping in general, higher levels of anxiety, right? And you could reel on the list as far as you'd like to go. But what are some things that we could potentially think of on an alternative basis than going, my family member is having difficulty sleeping and there's this drug that says PM up on the end of it, so I'm going to get them one of those and I'm going to help them sleep? What are some different ways that we can help by using your specific expertise to do so?
I love that Donna started in on sleep. Sleep is such an important piece, and there's so many non-drug things that we can do to support sleep. One of them is to reduce our blue light exposure. How many of us are staring at screens or reading on an e-reader? So taking some steps to reduce that blue light stimulation and wearing blue light blocking glasses or choosing not to use screens at least an hour before bed, keeping the lights low. Our bodies manufacture their own melatonin in response to low light levels. So having a nice dark environment to promote sleep. And also, if you can, get out and get sunshine on your face, unfiltered, to help with your circadian rhythms. Our bodies are meant to respond to these natural light and dark cycles. And when we're indoors all the time and we're not getting exposure to the natural sunlight, that has an effect on our sleep and wake cycle. So encouraging our patients to get outside and see the sun, and also reduce their screen time and that blue light. Those are some really helpful non-drug things that can make a really big difference. I have noticed, I personally have been having trouble sleeping, and I've been making an effort to go outside and walk every morning before 10 in the morning, and I'm not wearing my sunglasses. And it's made a big difference in how well I can sleep at night.
Wow. Donna, what about you? Any other thoughts there? I mean, it's so funny because Veronica, you kind of described something that Donna turned me on to a while ago. When it comes to, Donna did a tapering process that I think is really beautiful for people to hear. And she went, here's like your electronic time, and then you can move to like a hard paperback book, and then you can go no stimulus, like that you can transition yourself through the end of the day. But other things, Donna, that you would recommend or see, and we can talk sleep. The other one that I did want one of you two experts to talk about is anxiety as well. But please choose your poison.
Yeah, so I think we have to think about diet too, and that can be both things that can make us cause us to not sleep can also cause anxiety too. So caffeine and chocolate and some of those things, but also things such as red wine and cheese, especially aged cheese, and different types of cured meats. So those can be problematic too for people. They can increase heart rate and cause anxiety in that way that people might not realize. So we do need to look at diet as well in regards to how well we're sleeping when we're having these medication, when we're eating these, and the timing as to when we're trying to go to bed too. So that is all a part of it. I definitely think that we do need to desensitize as our day goes on, so that, and especially the evening hours, so that we can actually sleep. But also going back to the very start of our program, what did you tell us that you do, Veronica, with your patients? You take 3 deep breaths. And so being able to breathe and meditate perhaps, or learning some techniques in order to lower anxiety can be super helpful. So I think, full circle, it's these non-farm things that we can do in order to help us and move us in that right direction, so that maybe we don't need the medicines. And I know that there's a lot of people out there, and some people do need the medicines because they've tried these things and they just haven't been successful. But keep trying. And sometimes you might need the med intermittently, or maybe you do need the med, but keep trying, because eventually maybe your body can get used to that change.
Practice makes perfect. And I tell patients who tell me, oh, I've tried that deep breathing thing and it doesn't work. And I encourage them to keep practicing it, because at some point it's going to work. And maybe for, each person is going to be different. And maybe it doesn't let you get rid of that medication completely, but what if it allows you to reduce the dose? That's still a win, because even when we lower the dose, we're reducing the amount that our body has to clean up and get rid of in our body. And we're also reducing the dose can help reduce the side effects, because many side effects are dose dependent. So when we're using a high dose, we're more likely to have side effects than if we bring down and get to a lower dose. So all of these things, even if we never get rid of a drug completely, we're still successful if we can reduce the dose by using our different lifestyle choices, food choices, movement choices, and breath work.
Wow. I think that's beautiful. I have one last one, and I'm going to ask it just for my grandma who passed away a few years back. And so she called one of the medications she took at the end of her life melatonin. And so what are your guys' thoughts, I guess, and advice to those individuals? And then Veronica, please make sure with your commentary, you let folks know how to get a hold of you and learn more about you. But what are your guys' thoughts when it comes to something that's often reached across the, over the counter with melatonin supplementation, especially in our older individuals that are toward the end of their life struggling with sleep? Donna, you want to take it first, then pass it to Veronica?
Sure, I'll take it first. What I see a lot in the hospital is they'll start folks on a very high dose of melatonin if they can't sleep. And I don't agree with that. And there's literature out there that if you are going to start melatonin, you need to start at a very low dose. And it's really hard to find the low doses over the counter, too. So we're talking, a milligram at most. Sometimes people have even smaller doses than that. But once people are taking 9, 10 milligrams, that's a very high dose of melatonin, and that can cause grogginess and and issues for patients, cognitive issues, things such as that. So low dose again is what I want to say, and really on an as needed basis. I That's my preference for any kind of sleep med, is on an as needed basis, because melatonin was really originally meant for those that needed sleep because of jet lag, because their circadian rhythm was off. So Veronica, I'll let you take it from there, because I think you may have a bit more experience with it.
I agree with you. Start low. Start low and go slow. And there's good literature on melatonin microdosing. So using even less than 1 milligram, like 0.1, 0.3 milligrams, starting low. You can find them in drops. And I think it also matters the purity of the product that patients are choosing. I have found that there are products, like if I'm taking it for travel, if I get something that's just at the drugstore that's not the normal professional brand that I like to use, I am having to take a higher dose to get the same effect, probably because of purity and potency. So I think the quality of the product matters, but also starting low. And I typically don't take more than a milligram. I try to start with a 0.5 milligram for myself.
Exactly.
Beautiful. Oh, any monitoring elements, Veronica, that you'd plug in there too for individuals that are saying, hey, we're starting on this 1 milligram. How are you helping your individuals that are taking it to say, is it working for you? And when do you go up or down or stop?
Taking note of how you feel the next day, or if you're using any sort of sleep monitoring tools, like some sort of wearable device that's giving you some information on how you're sleeping, but also paying attention to how you feel. Do you feel rested? Is it easy for you to get up and start your day? And if you don't feel a difference in how well rested and how you perform the rest of the day, maybe look at something else after you give it a few days try.
Okay. That's fantastic. Veronica, thank you so much for all your wisdom and the information you provided today. We'll make sure that in the show notes, we plug in any links for you to be able to get a hold of Veronica and connect her offline. She's really an incredible resource and very thankful for her today. Donna, any parting words for us?
Just thank you again to Veronica for sharing your time with us. And I think it's just important that, clinicians and patients reach out to your pharmacist for assistance with areas of non-farm and farm type of treatment. So we're here to help, and please keep us in mind.
Awesome. Have a great rest of the day, everybody. Thanks for joining.